All right, and as we switch to the last speaker before our morning break, I'm really pleased to introduce Dr. Sandra Carroll, who is a professor and vice dean in the Faculty of Health Sciences and executive director of the School of Nursing at McMaster University. She's also an associate scientist at Population Health Research Institute. Welcome, Dr. Carroll.
Well, I'm happy to be here. Thank you, and perfect segue. Thank you for the invitation, Brianna, to come today. And I really enjoyed both keynote talks, and there were a lot of intersections. The team and the vice dean part that, I might read all those books this summer, and the discussion that naturally talked about the patient voice in this genetic testing conversation. So I've thought about it a lot, and I've been pulled away from it for a little while because I'm in my 7th year as dean, but I wanted to speak about the patient voice in knowledge translation. And I'm not a knowledge translation expert in any way, but I have done a lot of work with patient engagement, and I think they're interchangeable in terms of what we're trying to do. So let me just make sure I can, oops, I have to be able to read. So this is called Harnessing the Patient Voice to Improve Knowledge Translation in Cardiology. So I'm just going to give a little bit of an overview, because how I landed on doing some of this work, it really came from patients and what they were saying to me. So I'm going to speak a little bit about that and the patient engagement work and some priorities in cardiovascular research and KT in terms of where we are now and where we're headed. So I have a really good story. Well, I think it's a good story about a research assistant sitting in a waiting room full of patients waiting to see an electrophysiologist. And the research assistant was either waiting to get permission or to access the circle of care or to see patients, I can't remember. And she was observing and listening to the conversations happening in that waiting room across patients who were waiting for their appointments. And it was just so clear that there was a whole KT event going on in the waiting room with patients who were telling their experience and what was going to happen when they were getting their ICD and their own stories. Of course, you can imagine, they were all probably being seen for different reasons, so one person's story may not apply. But we actually ended up writing an abstract in the middle of a trial and presenting it at the ESC, calling it information from armchair expert ICD veterans in waiting rooms, because there was so much going on. And we ended up publishing the paper about accepting to decline an implantable defibrillator for primary prevention, because it was part of that work and it informed that work. So I just wanted to make the point that really it's the voice of the patient that is coming through in this type of work that I've been interested in doing. But that was a qualitative study, that decision-making study, and I am not a qualitative researcher like that. It's so hard. It may be easier now with AI because it could actually go through the text for you, but I'm not sure yet. So I engaged a group. I was doing my PhD at the time, so I had this proposal, I had this idea. I said, let's do this, and it led to a development of a decision aid. And I wanted to emphasize the patient's voice in that process, because I'll speak about what KT is, but every step of and some of what Cindy was talking about, every step of developing the tool that was meant for patients was all done by the patients, who they picked the words, they tested it on each other, their families were involved. And so it's a lot of work to undertake in order to ensure that you are hearing the voice in those deliverables. So I have to move over to see my slides. Implementation of these kinds of tools is the biggest challenge in practice, because then you're entering a system and there has to be time involved for that. But I'll speak to that in a little bit. But I love my armchair experts. I think they still are in every waiting room and offer a lot of advice. Tim Hortons is also another location. We were going to do a study just sitting in Tim's to hear the talks about blood thinners alone. It just could go on forever. And that's where I got rat poison. We hear rat poison from the Coumadin days because we put it in a teaching video for our undergraduate students, and nobody knew what I was talking about. And I said, talk to the patients. They'll tell you what rat poison is and how they don't want to take it. Now we have a new generation of drugs, but rat poison's still out there with Coumadin. So that's how they perceive it. So in terms of patient engagement and inclusion, and we have a lot of well-established norms now in terms of doing our research and expectations about having that voice in the work. And now there is a much more of a history of worldwide inclusion and some really fantastic organizations that build this into their program. CIHR, PCORI in the States, and England we all had similar. England's organization has gone through a couple different iterations of names, but they're all patient engagement organizations. But also PCORI was funding work that built the patient into all of the work, and organizations that now support the patient partners in that work. So we're doing really well in Canada, I think, in this arena, because we have some great organizations, and I don't have them all listed, and I don't have foundations listed or patient-specific. We just did a snapshot, but it really can take place in a variety of ways, and some of this has already been touched on with a great discussion about genetic testing. But as a committee member or being on our advisory board, really important, especially when you're starting your research projects, that you start that way and try to encourage it throughout. But also as a research team member, that is you're not a participant in a study, you are actually a team member. And we have done this, and we did some work together, Jeff and I, with CSPN, and it takes work to be able to include this in your projects throughout the whole lifespan of a project. Stand on my toes. And also including patients in the methods. So I have a paper after this where we did a large scoping review. We couldn't meta-analyze of looking for that patient engagement in the methods, because then it really, you can tag it back to your outcomes. But if you're just having a little bit of a discussion at the end of a paper about patient engagement, you really can't claim that they've helped build the study, been a part of the study, been a study member. So I think that all of these groups, CANET, CSPN, and HiRO, of course, are really great examples in the cardiology world in this wonderful organization of where we've really come a long way. And I would hope that the patients and families who are involved feel the same way as we've really grown. And I don't know if the font's big enough for you to see some of the titles, because I don't think I can see it from here. But we know in cardiovascular research that we publish, we know that including patients and families can make it more relevant, but we don't see our patients subscribing to the journals that we're publishing in. So we have to take that voice and put it where our patients are going to want to access it. So that's where the patient foundations and organizations come in to be able to be the voice to carry and translate some of that information. And as we know, KT was really that part of our grants at the end. If you remember, what is your KT plan? And really the integrated to KT sort of hasn't demanded that you start to build it right from the beginning to the end. But so I think we've come a long way in terms of building it in. But I wanted to just talk about knowledge translation, how it's defined in the world, because not everybody does knowledge translation research specifically. There is a whole community of folks that do that work in implementation science. And the difference, there's sort of two important areas in inquiry, and that's the KT practice, where there are activities undertaken to move evidence into practice, and strategies to adopt and integrate the evidence to make changes in practice within specific settings. And then the KT science is where the scientific study of the methods to promote the uptake. So there really are two different, organization of the data two different ways to organize the data in order to move some of this along. And I think, it isn't always, there are some instances where it's a little easier to put something into practice. If you have determined that a drug is not safe and it's not to be used anymore and the evidence is there, well, then you can change practice a lot easier than saying, well, we know that we're getting some improvements in quality of life if patients attend this rehab clinic. That kind of change is a lot harder to move because then you need much more system. You need organizations to invest. So it is really different how implementation can happen of an important change. And then where the patients fit in that, they'll say, well, we want to go to rehab. And so the organizations have to catch up with resources to support that type of change, and they have to buy into that change. But Canadians, we are good about evidence-informed decisions within our healthcare systems to try and influence policy. So I've just included a couple titles of different engagement and papers that focused on that. The scoping review was where we just went for the methods to see if patients were involved in the methods, so you could say that patients are linked to outcomes. And I'll comment on the "I don't know what you're talking about" paper because we use the word values a lot in statements, hospitals, everywhere, the values, and when you ask a patient what they value, the answer was, I don't know what you're talking about. What do you mean by my values? You really have to build context around that to make sure the message is correct, in the sense that my religious values, my finance, like what part? So, we're in this arrhythmia world. You really have to tailor that conversation to that, you might have a life-threatening arrhythmia. So, what's important to you? And that gets you to the values, but it wasn't easy. And the patients told us it wasn't easy. So we thought that would be a title that might be catchy. So then when we get into the knowledge translation evidence base, which is quite large, we have some classic models that are applied. And I guess when you're writing a grant and you have a project, you've got your model. If you actually follow the model through, you can, the voice will be carried through of your patients if they have been involved since the beginning, which is encouraged. So the integrated KT, is from beginning to end. And of course, Ian Graham in Canada is really just a real pioneer in that work. But it has grown somewhat in the last 2 decades. So in cardiology, and I'm probably not able to capture every element, but when you think about the multitude of evidence that is published every year, every week, every day, the results are not often implemented in all cases. And when I gave the example of a cardiac rehab program versus a drug that's creating harm, there's harm. It's very, very different to be able to put it into action. So just to think about that. When I reflect on, I'm in the defibrillator world. I was not as much so now, but and I think we're into a few decades. Go back. I've been in healthcare for several decades. I'm not even giving numbers, but when patients received ICDs, it was only to be in a clinical trial. You had to be in a clinical trial to get your first device. So I think it was dynamite, Jeff, where we were putting them in for secondary prevention. SIDS was first. I wasn't there for SIDS. And then you could only get one if you were in a trial. So there was all the language, and the way patients were sort of taking in the information was that, you are a candidate for this prize and you're going to get the ICD. And then, once the evidence was out and putting it into practice for primary prevention with MADIT2 and all of those wonderful trials, which were kind of small for the time, putting it into practice really was, about referring and getting the patients to the right physicians who were at risk, because it was a whole different era for primary prevention when you might have an arrhythmic episode. So then the patients had to think about it, so it was really an elective procedure, versus if you'd already had an arrhythmic episode, it's a bit of a different experience. So that's where patients paused and might have said, well, what if I don't? What if I don't get a device? And conversations with patients then really, really grew. And that's where having decision tools can assist with that. But, and that's very arrhythmia specific, but in cardiology, there's a lot of opportunity and, to engage patients to be, help you build. And I don't think I have that example. I have to go the other way. I can't go that way. And thinking about implementation science, and I'll go back to Atlas after, how we move into practice. I think from what I've just already talked about, the models that exist, which are really great to follow. I'm not a model and theory person, but they actually really do work. If really do. No. So I'm not always the greatest thesis supervisor. I'm going, okay, let's get a model. But they do work because the time has been put in and they're linked to the outcomes that you measure in your research. And those outcomes matter to patients if that time has been put in to ask patients what is important to them, maybe avoiding the word values, but asking patients what is important to you, and then linking an outcome measure or tool that will capture that. So these are a couple of frameworks. These are all well known for folks that do this kind of work. Participatory research was the other term that was used before we entered into the patient engagement and the funding that came to Canada through our provincial and federal agencies. So I think the effective strategies that will help take the patient's voice through must be active. And from what I said about asking the patients, that's part of it, but also once you have the evidence, you tailor the information. These are well-known audit and feedback. Some of this you were talking about, Cindy, in your videos. So you're nodding away. You're my best audience member right now. It has to be multifaceted. And I don't know if there's any patients in the room today. I actually wasn't sure who the audience was. Thank you. So I hope you have some questions for me, but it's so important, but it has to be realistic because, patient partners may be volunteering their time, but perhaps they should be receiving income to be participating in trials. That's been well known and discussed. But, we need to listen and actually carry it forward and not create opportunities where it's really just symbolic. You're there, you're the patient partner. Really carrying it through makes a difference. But it does take time. If you have a 5-year trial, it's a long relationship. So you want to be able to keep in touch. And the patient partners might change over time. And they probably might not want to be the spokesperson for the results of a study, or they might. But if you ask, you will get the answer for that. I'll just comment on Sandra from the West, Sandra Lauk and colleagues. She published a great paper about closing the no-do gap, and again, addressing some of the issues. And one of the things when we have the patient voice, we have to ask ourselves whose voice. So in this work, you will get the voice of the person who shows up. So I'm always asking about the ones who aren't able to show up and don't show up, and then why that is happening. I think we all know there are many reasons why that's not happening. So we may not get that representative voice. There's always the voice that is silent. So another great model, just use the model when you're building a study. It'll help. And in cardiology, I think we're headed in the right direction. I'm not fully immersed anymore, but I think we started with it all being about conversations with clinicians, and now we've seen that there's an interprofessional lens that really can help carry through the translation and impact in our clinical care settings, but in the communities as well. We all know we need administrative buy-in and support and resources to actually take it to the level that will be sustained in organizations, and keeping those KT strategies with patient partners and families embedded is obviously critical. That one journal I'll just speak to, because we put I just was published our Atlas paper in it. They have a whole KT corner. The journal has gone over the top to really have the voice in there. Again, I want to make sure patients have access to the journal. They would have to have free access if they're interested, but they ask for a slide or things that are visual in terms of the KT corner, so that there are different mechanisms for the information to be received. And also similar but related, or that if the libraries now actually have so many resources that are just film, video, different types of ways to deliver the messaging that isn't just the paper. So we've really come away from printed paper as the way, and we know that passive approach isn't effective. So there are many opportunities, and I guess we could ask AI if we get lost to tell us what the results are, and then it'll be interesting to see what is relayed by. So I've included some resources for you. I just really wanted to have a discussion about the voice of patients being carried through, and welcome any of your thoughts, especially for the patient partners that are in the room. There's been a lot of work done, and I hope that it is sustained in that. And I thank you for your time. I might have gone a little fast. We're ahead of schedule today. There's Katie. I haven't seen Katie in a long time. I know, 7 years. I know. It's been 7 years. So.
Thank you so much for the great talk. We'll open up questions to the audience.
I've got it here if you want it.
No, this armchair has a lot of potential, I think. In fact, all of these clinics could actually plant your armchair person, because you know what? They're there anyway. And I think the negative is as much potential as the positive. And I'm going to focus on myself for a minute and tell you what I think is a humorous anecdote. But I had an aortic valve replacement 6 years ago at UHN, and my surgeon was Tyrone David, and I think most of you would know he's a legend, and he's an old legend. And so the scenario is that I was going for my post-op, and I actually did very well. So I, was walking down, and I was pretty chipper, and I felt good, and I met a couple coming along, and the guy was there for his consult. He had not had surgery. So he assumed I was there for the same reason. And we shared, our, same valve, and you can imagine. And he said, and finally he said, "You mean you've had your surgery?" And I said, "Yes, I'm the result." And I could see then he started pumping me with the questions, like, what did he need to know? Now I'd like to think I was sensitive enough. I wasn't going to tell him all the horror stories I had been through. I told him, I gave him some advice and so on. And then Dr. David walked through the room. And if any of you know Dr. David now, he's very bent over, and he has this white hair. And the guy said to me, "He's going to be my surgeon." And I said, "Well, here I am." So I just think it's an anecdote that happens in every waiting room. And so if you plant your patients accordingly, you may be able to cover a lot of knowledge translation. I'm being facetious.
I know. That's an excellent antidote. And I do remember Tyrone very well from the old Toronto General days, when he was very tall. He was very tall. And but the important thing, and other cardiovascular, the open heart surgery programs in Hamilton used to have peer partners that they'd match you with. And I don't know if they still have that, because that would be the example of that KT from a stakeholder. And they either stopped it, or you have to really have the resources to keep all the partners engaged. And have the right information to share. So the important thing would be that the correct evidence is the narrative, that folks are delivering the right information to folks, because it could go the other way. But planting them in the armchair is a great idea with several opportunities to share, because the passive flyers on the wall don't quite do it. So if you have the armchair expert there to assist, it would be kind of interesting to see. So, Jeff Healy.
So Sandra, great talk. You made a good point about accessing the outliers, right? Because we tend to study the average results and report the average results, and this is great, but often when we have a clinical issue that is challenging, it's not about a circumstance that's in the middle of day-to-day practice. It's something out on the edge that's really problematic. So how do you access that voice? Because that's really where you can really potentially have a big impact. So
the voice that won't volunteer and may not be, the high educated volunteers that we see, people that are often retired healthcare folks volunteering to be our patient partners. So it takes work. And I think you need to connect with communities then. You need to connect with communities in a more meaningful way with organizations that will let you in, because you need permission to really go into different spaces. But I think it really is untapped, that we're not accessing the voices of those who won't speak up in a room, or won't put their hand up to be the peer. Now, there are different, we have had some success in the mental health arena with, we had some graduate students who went out into their community and started during COVID, because nobody would talk about mental health in their community specifically, and they had great results, but they had access to the community. So I think it's taking those extra steps. Now we know how to do some of this work, but we really want to make sure we're doing it that is representative of all communities. You can't get everybody, but we could all do better reaching those that we know we're not reaching.
To volunteer. I don't think that's clear to the patient either.
So how do we invite patient partners to be? Yeah. So then that's the extra step of actually advertising where people will see. So sometimes it is a local newspaper. Folks read the newspaper, or it's back in that coffee shop. You've got your flyer on the wall, and if you get buy-in from the community, and then they tell their friends, that's how it happens. And it really does happen. It's some of those coffee shops. If you sit in a coffee shop, you will hear a lot of cardiac coaching going on, a lot of tales. But then you also might hear, hey, we could get involved in this, and it could happen that way. So we'd have to sign Tim Hortons to fund a grant. Who wants to do that? I have a question. Okay.
I'm on several different forums online, Facebook, Instagram, ARVC, and I have ARVC, so that's what I'm interested in, but there's one for every single SADS condition. But I noticed that there's no expert on there, and I know it's very difficult to, I don't know if anybody would be willing to give advice, but the advice that's going back and forth within these patients is absolutely so scary. People asking questions, people putting their ECGs up. Hey, I'm not able to get to my doctor till next month. What do you guys think? Hey, can I have a baby with this condition? Hey, can I do this? I'm like, it's just, I just watch it out of curiosity and I don't respond, but it's amazing the misinformation that's going back and forth there. And I just see that as being a really good place where an expert could be on there and not giving advice, but just giving a link. Like, you don't have to say you can do this, but here's a link to a study, or here's a link to some advice, or here's a link to a place so you can get the information. And I don't know, it just seems like those are the people that are not coming out, but they are online and they are asking the questions there. It seems like a pretty easy place to get the information out to them.
So excellent. And I think some of the online forums that I've seen historically do have experts that might go in and out in communities. But again, you'd have to have a system to support that ongoing KT in those environments, because it is you'll get multiple different issues in those forums. But putting an ECG up, but I actually am not surprised at all. And when I've gone through some of those sites, you really see a lot of personal information. So it starts to get a little challenging about where you have boundaries for some of this. So, often the forums now on Facebook will have a lot of rules, and they do have an administrator, but you got to have that administrator who's going through the content and to ensure it's a safe environment. I mean, emotionally safe as well for folks. So great idea. So I don't know if that's a grant though, so we could make sure we have volunteers who want to moderate, but really just provide the links to evidence. We have so many organizations that synthesize evidence. That's what they do. And all of the organizations associated with arrhythmia care have the evidence. So again, it's putting the links up, leading people in the right direction, but you need an admin to do that. Is somebody over here?
Is this on? Yeah, that's on. I just wanted to make a comment. You were talking about the silent patient.
Mm-hmm.
So in our case, we're the parents of the now silent patient. He was vocal at somewhat near the beginning of his diagnosis, when we started doing fundraising in our city of Kelowna to get an EP lab. We went on a big media blitz, et cetera, et cetera. And what ended up happening, because he went public with us, he had an older gentleman look him up in the phone book and phone him and berate him for being a spokesperson and being positive about having an ICD in him, and how dare you talk about this as a better life, and et cetera, et cetera. And our son was 22 when he was diagnosed, and that sent him right back into the oblivion of don't talk about it, don't do anything. I want my name erased off of the media. It will interfere with my work and that sort of stuff. So, so sometimes that happens, and we have continued on because we don't want other families to fall into the pit that we went into, because we didn't have any resources, because we weren't in a big community. And so so we told him that we're continuing on, but his name never goes in the media anymore. But that actually does happen to people. And when you don't live in the big centers, you don't realize that other people can search you out. And he was a person who did go online to get information and go in these chat rooms. And he did find somebody in his very early stages, and then she died. And that also triggered a whole thing, but he didn't tell us for a whole year because he didn't want us to worry. And so sometimes the patients are silent, but you never really know why. So that was our story. So just wanted to pass that along.
Well, thanks for sharing that story. That's an incredible experience that you've been through with your son, and really relevant to sort of the rules of engagement. And it takes work that there's first names. You should never have your last name out there, but people can still find you. So there's sort of a balance. And we all know what's happened with Twitter, now known as X, and how bad things can go. And how, trolls are there. So it's, you have to build something that is going to work. And I'm talking in the context of cardiology in general, in the research world, about how to, talk about the results of, of a large study that can, change care. But when you're into the forums, that is a different environment, and it can go, as you say, and look at the silence of somebody not feeling safe anymore, your son not feeling safe anymore because of how he was approached. And so that's a very extreme example, but I don't think you're alone in what can happen in different contexts. So it just really makes us all think about making sure that there's safety involved in all of these initiatives associated with sharing information, sharing personal information too. So
We'll make last question.
Yeah.
I'll just quick second as the family doctor in the room, and there's other nurse practitioners in primary care. Just this is probably a perfect opportunity, but also with the genetics is just remembering the role of primary care. I mean, innumerable times the patients will see the experts in the field and will come to my office saying, "I'm not going to do this unless you endorse it." So, which always gives a bit of a shake. And of course, we have to be not experts, but so knowledgeable in so many things that as they're coming to us for that trust, for that discussion, et cetera. So there's not a lot of mention of primary care during these symposiums. That's totally fine. But this, especially knowledge translation, genetics follow-up, especially rural, there aren't it's forums, yes, but they're often back in our offices too. So just advocating, as many of you do, just the details in your letters. The details in your consult notes, we get really detailed genetic notes now compared to historically. It just makes our job a lot easier as we're helping with knowledge translation. And I think if you are facing difficult patients that you really think, this is, of course, it's patient autonomy, patient decision, but if you need help getting an important life-saving decision across the line, the details in the letter or even a phone call to the primary care can be very helpful.
Well, thanks so much for that comment. I love primary care and I love nurse practitioners too. So I have been advocating for that just in my other job as the dean. But it's a really important gate between, information, and a lot is, we'll give it to the family doctor to, they'll use a decision aid. I don't know. You don't have a lot of time. So if you have a team, then it's fantastic if some of that can be shared. So thanks for offering that comment.
Thank you again, Dr. Carroll, and for our patient partners sharing their stories in the audience. I think